It's great to be here. I wish I was there in person, but someday that's going to happen. And today, I'm really going to talk about really kind of the nuts and bolts of maintenance therapy in platinum-resistant and platinum-sensitive ovarian cancer, not just focusing on upfront newly diagnosed folks, but also in the recurrence setting as well. So I'm going to start off is what is maintenance therapy? And this is the definition that's taken from ASCO's. ASCO is the American Society of Clinical Oncology. They're cancer.net. It's a website that's kind of filled with different practical pieces of information. And this was on there. So maintenance therapy is the ongoing treatment of cancer with medication. So using medication after the cancer has responded to the first recommended treatment. So you're really trying to continue to keep this cancer in response. So why is maintenance therapy used? One, to prevent the return of the cancer. Secondly, to delay the growth of an advanced cancer after the initial treatment. And then a maintenance therapy can be given for long periods of time in either of these situations. So that maintenance therapy has to be safe and well tolerated, because once you've finished up chemotherapy, you want to be able to really be well enough to do what you want to do and not feel bogged down by side effects. So maintenance therapy treatment plan can include any of the following: chemotherapy, hormonal therapy, immunotherapy, or targeted therapy. And then there's something called switch maintenance versus continuous maintenance. So switch maintenance basically means you're on a drug, you're on chemotherapy, but the maintenance therapy is a different drug. So you've switched to a different agent. Versus continuous maintenance is like bevacizumab. You're on bevacizumab or Avastin during initial chemotherapy, chemotherapy stops, but the bevacizumab continues on. So that's continuous maintenance. Again, just for definition's sake. So what influences the type of maintenance therapy that's selected? One is the clinical situation. So is somebody have a new diagnosis of ovarian cancer, or is it recurrent ovarian cancer? Is the cancer platinum sensitive or resistant, meaning if the cancer is really being sensitive, so in response to chemotherapy. And in the recurrent setting, it means that the cancer has grown by some measure after 6 months after receiving platinum-based chemotherapy that's platinum sensitive. If it's less than 6 months, it's platinum resistant. And those are very generic definitions, and they can be moved a little bit, but that's the basic definition. And then the underlying genetics of the cancer. So is there a BRCA mutation present, either inherited from mom or dad, or sometimes, especially in high-grade serous cancer, for 6% of the time, the BRCA mutation can only be in the cancer. It's not inherited, it's just in the cancer. And then something called homologous recombination testing, or HRD, homologous recombination deficiency testing. You'll see that term, and we'll talk about that. And then do certain medical problems that somebody might have prohibit the use of certain maintenance therapies. What type of ovarian cancer one has can also help select the type of maintenance therapy. So this box talks about the different types of ovarian cancer histology that we see: high-grade serous or high-grade endometrioid, low-grade endometrioid, low-grade serous, clear cell mucinous. The types of histologies or pathologies where we do use maintenance therapy a lot are high-grade serous or endometrioid. And because of the sensitivity to drugs like platinum, because of underlying DNA repair problems, drugs like Parp inhibitors can be used. Bevacizumab or Avastin can be used regardless of the histology. So there's not a sort of mandate on what histology somebody has. But for high-grade serous or endometrioid, really Parp inhibitors are, we can't use Parp inhibitors in mucinous tumors. We should not be using Parp inhibitors in low-grade serous, just because those cancers tend not to have underlying DNA repair problems. I'm going to point out low-grade serous. I don't know if you can see my pointer. Hopefully you can see the pointer. But this is the type of a cancer that can be very sensitive to hormonal therapy. And that's where the use of aromatase inhibitors are now being used routinely in women who have advanced or not even so advanced cancers of low-grade serous cancer. And then maintenance therapy, the decisions around it should be based on published data. So we don't like to make up things. You want to make sure that the decisions that are being made are based upon published data. And then decisions have to be made in partnership with your oncologist, weighing the risks and benefits of the treatment, and then comparing that to how much benefit you're going to get and receive from that maintenance therapy. So high-grade serous ovarian cancer is the most common type of epithelial ovarian cancer. You may have heard this from other speakers, so I apologize, but 22% of cases of women have an underlying BRCA mutation. So 16% are germline, meaning inherited from either mom or dad. And then 6%, as I mentioned before, are solely within the cancer. No inheritance, cancer just happens to have a BRCA mutation. 50% or half of high-grade serous cancers, sorry, I'm having trouble talking, have underlying DNA repair problems. So the cancer cannot repair DNA properly, AKA homologous recombination deficiency, or HRD. And these underlying repair problems for DNA really allow us to use drugs called Parp inhibitors. The BRCA proteins, BRCA1 and 2, are responsible for the efficient and precise repair of breaks within DNA. And for double-stranded breaks specifically, where a break is across the DNA within the two strands, that is a lethal event to the cancer cell and needs to be repaired precisely. So maintenance therapy, I'll start with Parp inhibitors first. So maintenance therapy for Parp inhibitors started back, yes, in 2012. Our first trial that we did at Farber was a 2008. So it's, I remember the name, trial 08275. And this tested olaparib, the Parp inhibitor olaparib, or Lynparza, as some of you may know it, when somebody completes chemotherapy and the cancer is in remission. So it's really important that for Parp inhibitors, that the cancer be in response to platinum. It's not just good enough to have kind of stable disease, at least it's for me. The cancer really has to show responsiveness to platinum, and then the olaparib can certainly be considered. And the FDA approvals for Parp inhibitor maintenance in platinum-sensitive ovarian cancer in response to platinum-based chemotherapy. And this is for patients who have recurrent cancers. This is for women with recurrent cancer. I'll talk about upfront cancer in a second. These are the different dates. So for the first FDA approval for a Parp inhibitor in the recurrent maintenance setting was back in March of 2017, so almost 5.5 years ago. So this is a table that shows the different FDA approvals for ovarian cancer. I think we really need to be, when we're thinking about prescribing drugs, as I mentioned before, following the trials and making sure that we're not causing any unnecessary harm to somebody. And I've mentioned this already, Parp inhibitors are used in high-grade cancers, high-grade serous, high-grade endometrioid, occasionally clear cells, but they really have to show responsiveness to chemotherapy, platinum-based chemotherapy. And importantly, following response to platinum-based chemotherapy. You don't want to add a Parp inhibitor when you're on chemotherapy because there's really could be significant overlapping bone marrow suppression. Treatment preceding the Parp inhibitor, as I mentioned, is platinum-based chemotherapy. And these are the 3 FDA approvals for somebody with newly diagnosed ovarian cancer, specifically for Parp inhibitors. And I happened to be in France for the ESMO meeting, the European Society of Medical Oncology meeting. So I was able to hear the 7-year follow-up of the SOLO-1 study, and then the final results for survival. And we'll talk about that on the next slide for the PAOLA-1 trial. So the SOLO-1 study is basically all women had an underlying BRCA mutation, and all of these trials are basically Parp inhibitor versus placebo. Nobody knows what anybody's getting. In the PAOLA trial, the Parp inhibitors combined with bevacizumab. So if somebody's getting bevacizumab with their upfront chemotherapy, and they happen to have an HRD test that's positive, so that myriad score is 42 or higher. And even if there's no BRCA mutation, there's an approval there for using olaparib. And then niraparib has more of an open approval. As long as the cancer is in response to chemotherapy, you can use niraparib. And it's important here that the duration of Parp inhibitor maintenance treatment is different. So unlike when we use Parp inhibitors in the recurrent setting, where there's kind of an indefinite use of the drug, Here, there's a hard stop, 2 years for olaparib, and then 3 years for niraparib. And it's really important that I'm definitive about this. I don't let my patients go beyond that time. And then for recurrent ovarian cancer, these are the 3 PARP inhibitors: olaparib, rucaparib, and niraparib. There's no really dictations on the, or that's the right word, but there's no like mandates on the who gets maintenance therapy, except you have to have response to platinum chemotherapy. And then, as I mentioned, the duration of PARP inhibitor use is indefinite until cancer growth or intolerable side effects. So I think we're learning a lot, and this is kind of an uncertain time in some aspects of PARP inhibitor treatment. So I took that last slide and kind of scrunched it together on the left. And what I want to really talk about, and this is complicated to talk about in a very short time, but it's, as we have long-term data from trials, we really learn 2 things. One is, what's the kind of output or the impact of the PARP inhibitor on survival? Because if you're seeing that the PARP inhibitor has got kind of a negative impact on survival compared to placebo, well, that's not good. We're seeing long-term toxicities and kind of following up on that. The issue that complicates some of these trials is that if somebody's on placebo and then they have cancer growth, they want to know, were they on the PARP inhibitor or were they on placebo? When they get unblinded, if they find out they're on placebo, then they want to go on a PARP inhibitor. So that complicates some of the interpretation of the data. Shouldn't affect survival too much, but it can affect something called progression-free survival sometimes. Especially if somebody comes off it early, then goes back on it. So here's the impact of progression-free survival from a PARP inhibitor. And in all of these categories, the PARP inhibitor has a positive impact on progression-free survival, meaning the duration of the time that the cancer is in remission. So all of those score positive. Now, the survival benefit is where it becomes a little more complicated as women cross over. So we heard the 7-year results for Solo 1 trial, and there's a significant trend for a positive impact on survival, meaning women are living longer on olaparib versus placebo, despite a little bit of crossover. For the Paolo 1 trial, definitely appears to be a survival benefit for those who have an underlying BRCA mutation, as well as those women who have HRD cancer and not necessarily a BRCA mutation. However, if you have an HRP tumor and no BRCA mutation, HRP stands for homologous recombination proficient, there actually seems to be a survival decrease. But it's important that the FDA has not approved the use of olaparib being added to bevacizumab in this setting. The niraparib trial, the PRIMA study, needs more follow-up time. We don't have information, long-term information on survival benefit. And this is where it becomes a little more complicated in the recurrent setting. So for olaparib, for the Solo 2 trial, only women with underlying BRCA mutations could be enrolled. And there was a survival trend in favor of olaparib that's been published now. For niraparib, the NOVA study, yes, there appears to be a trend for improved survival for BRCA mutated patients, so those individuals who have an underlying BRCA mutation, not for HRD positive, and then HRP is not fully known yet. And this is a really, in discussion kind of issue, and I think we're going to have some more resolution around this. But I have a lot of my patients come to me and say, so what should I do? What should I do? As long as someone's doing okay on the PARP inhibitor, not having any problems, I'm continuing it. And then the rucaparib data, the Ariel 3 data is going to be presented actually later on this month at the IGCS meeting in New York. So this is a very changing kind of how we're looking at PARP inhibitors with more long-term follow-up. And then, as I mentioned, that other outcomes of long-term follow-up of these studies really show that the risks of acute leukemia and something called myelodysplastic syndrome do rise in the recurrent setting when somebody's on a PARP inhibitor versus the upfront setting, and that women who have underlying BRCA mutations, especially germline have a higher risk of AML and MDS. And again, this is something that one should just chat with your physician about and weigh the risks and benefits of every drug. Okay, so this is a patient of mine. I have a few cases just to be hopeful and really to show the impact of these drugs. This is a 57-year-old patient of mine who noted abdominal distension in 2018. She had a large pelvic mass that you can see on CAT scan. She underwent primary cytoreductive surgery, found to have stage 3 high-grade serous ovarian cancer and an underlying BRCA2 mutation. She received carboplatin paclitaxel chemotherapy, entered a full remission, and then started olaparib as maintenance treatment she took for 2 years. She completed that almost a year and a half ago and is doing well and is without evidence of cancer. So, without the Parp inhibitor, I see thumbs up. That's good. Yeah, I agree. She has a much higher risk of recurrence. And then a 65-year-old administrative assistant diagnosed with high-grade serous ovarian cancer 2013, underwent surgery with no cancer remaining at the end of surgery, and then received 6 cycles of carboplatin paclitaxel, found to have a germline BRCA mutation. She was in remission until 2017 when her CN5 rose up to 200, and a CAT scan unfortunately did show recurrence. She was retreated with platinum chemotherapy. I believe she got carboplatin and liposomal doxorubicin for 6 cycles, then placed on a Parp inhibitor, specifically olaparib. And she's been cancer-free for 5 years and still on olaparib. So these are those amazing stories that, I don't think we had seen before, institution Parp inhibitors. All right, maintenance bevacizumab for ovarian cancer. Bevacizumab, as you know, is an antibody that recognizes a protein called vascular endothelial growth factor, and it's combined with chemotherapy and then continued as maintenance. So this is continuous maintenance as opposed to Parp inhibitor, which is switch maintenance. And bevacizumab has FDA approvals in both women with newly diagnosed stage 3 or 4 ovarian cancer, regardless of histology, and then also recurrent ovarian cancer, platinum sensitive. And this is the treatment is carboplatin, paclitaxel, and bevacizumab. And then the treatment here, and I clearly did not complete this slide, it should be carboplatin, paclitaxel, bev, carboplatinum, and gemcitabine, which is the OCEAN study. GOG 13 talks about the paclitaxel. And here, there's a definitive end date through 22 cycles total of Avastin, and then the drug is stopped. But in the recurrent setting, bevacizumab is continued until unacceptable toxicities or until the cancer grows. For platinum-resistant recurrent ovarian cancer, bevacizumab is combined with chemotherapy, so non-platinum-based chemotherapy per the Aurelia study. And this was FDA approved back in 2014. And this is the last FDA approval for platinum-resistant ovarian cancer. We're obviously hoping that that's going to change. I know Katie Moore spoke earlier today, and hopefully we're going to get mirvetuximab, soravtansine across the finish line for this setting. And then the chemotherapy that could be added to bevacizumab was either pegylated liposomal doxorubicin, aka Doxil, weekly paclitaxel, or topotecan. And then the maintenance treatment in the paper says could be single agent chemotherapy or single agent bevacizumab that's continued as maintenance toxicity. And I certainly, sometimes I continue the treatment more indefinitely, especially if someone's on weekly paclitaxel and doing well. But if they're starting to get neuropathy or skin rash or low extremity edema, then I'll just continue the bevacizumab alone. And then the duration of the maintenance treatment is until cancer progression or unacceptable toxicities. Okay, so moving to low-grade serous ovarian cancer, different histology, as I mentioned. And a lot of this work has been done by David Gershenson at MD Anderson. So we know that a high proportion of low-grade serous ovarian cancers have estrogen and progesterone receptor expression. It's interesting that high-grade serous also does, but in low-grade serous, that estrogen receptor is really receptive to hormonal manipulation. And we know that hormonal therapy can shrink recurrent low-grade serous ovarian cancer. So Dr. Gershenson, a number of years ago, looked at a kind of collected 203 women with stage 2 to 4 low-grade serous ovarian cancer. And they were all treated with surgery, then followed by chemotherapy. And then what he did was he looked back at how they did and then broke them into 2 groups. Those who had received no maintenance treatment, or those who had received hormonal therapy at the completion of chemotherapy. And the results were that women receiving hormonal therapy, and most of them received an aromatase inhibitor. These are drugs that block the conversion of estrogen or block the conversion of testosterone to estrogen and are used in breast cancer a lot, compared to women receiving no maintenance treatment, had their cancer stay in remission longer. And there's currently an open trial through the cooperative group, the NCI cooperative group, group NRG. This is called GY019. And essentially, it's a really potentially paradigm-changing treatment where women are actually receiving an upfront aromatase inhibitor, letrozole, versus carboplatin paclitaxel chemotherapy, followed by letrozole maintenance in treating women with stage 2, 3, or 4 primary ovary or peritoneal cancer. So this would be a real game changer in how we think about this cancer. You can replace chemotherapy with letrozole. And this trial is ongoing currently. So here's an example of where aromatase inhibitors can really be quite impressive. This is a 79-year-old patient of mine. She presented with 1 year of vague abdominal symptoms. And eventually someone did a CAT scan and she was found to have intra-abdominal carcinomatosis. So basically peritoneal nodules and masses within the abdomen and a pelvic mass on CAT scan. She went to surgery and the surgery showed a low-grade serous ovarian cancer, and some residual cancer was left behind because of the inability to resect the cancer fully. Her CA-125 before surgery was 1740, and post-surgery just went down a little bit to 1690. I started IV carboplatin paclitaxel, and her CA-125 only fell to 900 after 3 cycles of chemotherapy, and unfortunately, she developed significant neuropathy. Arimidex, which is an aromatase inhibitor, I actually added it to chemotherapy to that. That's not the usual way of doing things. Usually you want to start the aromatase inhibitor after chemotherapy is done. But I thought, well, we're not doing so great with just chemotherapy alone. So I added the Arimidex to chemotherapy just because there's no overlapping toxicities. And the Arimidex continued after she completed chemotherapy, so continued as maintenance. At the completion of chemotherapy, her CA-125 still did not normalize, but after chemotherapy, her CA-125 continued to fall steadily on Arimidex alone. And 4 years later, her CA-125 is 10, and she is without evidence of cancer on scans and actually feeling quite well. All right. So a few other comments. One is on antibody drug conjugates. I think you guys have talked about this. These are drugs that recognize a certain protein on the cancer cell, and the antibody is connected to a potent toxin, chemotherapy drug. So there are a number of paradigms now when the antibody drug conjugate is actually added to carboplatin, and then as maintenance, the antibody drug conjugate is given by itself. And there are several examples of this ongoing currently. And then immunotherapy agents. So when a checkpoint inhibitor is added to chemotherapy, and then the checkpoint inhibitor is added or is continued as continued maintenance. So this is kind of a synopsis, including data that was presented last week in Paris. So this is what are the results of addition of immunotherapy, specifically a checkpoint inhibitor. So not anything that you just heard from Mir that is kind of novel. These are checkpoint inhibitors that you see on TV that are used for lung cancer and melanoma. So the addition of immunotherapy to chemotherapy to date shows no benefit in ovarian cancer. So it's important that, we recognize this. So we're not using unnecessary medications, but there are 2 trials now in the newly diagnosed advanced cancer setting when a drug called avelumab was added to carboplatin paclitaxel versus carboplatin paclitaxel alone, or the anti-PD-L1 drug atezolizumab added to carboplatin paclitaxel bev. The Javelin 200 looked at the addition of avelumab to liposomal doxorubicin and did not show any benefit. And then just last weekend, We heard results of the Atalante trial, which was adding atezolizumab to platinum doublet chemotherapy plus Bev. And these have all been negative trials so far. So, there's side effects to immunotherapy, and we shouldn't be using them. We shouldn't be using them, and we should be thinking about other alternatives to this. So in conclusion, maintenance therapy is defined as the ongoing treatment of cancer using medication after the cancer has responded to the first recommended treatment. And maintenance therapy is used to prevent the cancer's return and to delay the growth of cancer after treatment. Maintenance treatment needs to be well tolerated since it may be given for long periods of time. And as I think you're hearing from Parp inhibitors, it's important to really understand the toxicities during treatment and very early on. But then we need to follow folks out even when they're off treatment to make sure there's no long-term side effects that we're seeing. The types of maintenance therapy for ovarian cancer include bevacizumab, Parp inhibitors, hormonal therapies, chemotherapy, and several others are in clinical trial testing, such as immunotherapy. Long-term results of Parp inhibitor maintenance studies may change recommendations, but not as of today. So as of today, I think we have to be following with the FDA in the package insert, and we'll see as this year unfolds and more data comes out. And then the decisions about the appropriateness of maintenance therapy and, if used, which one should be selected should be made based on clinical trial results, the underlying biology of your cancer, and what genetic vulnerabilities exist. Other medical problems you have, we don't want to exacerbate or make something worse. And then after careful discussions with your oncologist, really weighing the risks and the benefits of treatment, i.e. the toxicities and side effects, but then also really honing in on what level of impact this treatment is going to have on you. And thank you so much. It's a pleasure to be here.